First of all, before we start with puncturing the groin, we prepare the materials. In this case, the patient is intubated because of personal reasons. The following materials are made available on the table: compresses, Selding puncture needle, short 4 French sheath, a Benson wire and a J wire, both 0.035. One wet and one dry swab. Tool for scarifying the skin and local anesthesia. The patient is slightly obese. The pulse is felt below the inguinal ligament. The pulse can be felt easily, but due to his obesity, it makes it more difficult to determine the precise location for performing the puncture. The scarification tool is placed on the targeted puncture site. There are often short fluoroscopies performed with a narrow display, which is only carried out when the precise height is not absolutely clear. You can see that we have placed the scarification tool at the lower third of the femoral head. This is a very good position. Even when the patient is anesthetized, local anesthesia is always performed in addition around the vessel to preclude any potential spasm. I start to locally anesthetize the vessel region by shortly rubbing in the local anesthesia with a swab. The open, I use the scarification tool to scarify the puncture site. The Selding puncture needle is then placed on the site accordingly and injected through the vessel at the angle of 45 degrees until it reaches the bone. We check the needle position by means of fluoroscopy. It may be that the needle is placed too laterally. When injecting the needle, the pulse could not be felt optimally. We remove the needle mantra and slowly withdraw the needle with a little bit until blood emerges. Then we slowly introduce the 0.035 Benson wire. The insertion aid is moved backwards onto the wire container. The 4 French sheath is inserted with a slight rotating movement and then pushed forward by using pressure. The sheath is then flushed and the wire is cleaned with a wet swab briefly and kept wet. Thus, the use of the sheath is then completed. The next step is now to place the selective catheter. For chemoembolization, to probe the celiac trunk through the transfemoral access, we use the 4 French sidewinder type 1 catheter as standard catheter, which we will now insert. I take a wet swab with my left hand to be able to simultaneously clean and keep the wire wet when inserting or pulling it out. The assistant doctor gives a sign as soon as she holds the wire. The wire is pushed forward until it reaches the aortic knob. I will now try to configure the sidewinder catheter in the left subclavian artery by means of rapidly rotating it in clockwise direction. This went very well. I will now continue to slowly and carefully pull the sidewinder catheter downwards. It is very important not to pull it into a vessel branch by force, thus causing vessel injury. In principle, some work groups use the Benson wire, protrude it 1 cm off the sidewinder tip. However, this is not our routine procedure. We remove then the wire, connect the one-way stopcock and flush the sidewinder catheter. The sidewinder catheter is now above the celiac trunk. I rotate it in clockwise direction to find out where we are with the tip of the catheter. I'm at front, I'm left, rear, I'm on the right side. I continue to rotate to get a feeling. I'm at the front, I'm left, I'm rear, I'm on the right side, I'm on the front side. Thus, I always know the position of the catheter tip. I will now smoothly pull it downwards, seeking to pull it in this manner into the celiac trunk. Here we see the phrenic artery and here we have the celiac trunk. The catheter is flushed once more. Now we apply the contrast agent pump. For this overview angiogram, you may use 30 to 35 ml of contrast agent, applying a flow velocity of 5 to 6 ml a second and 2 images per second.
Hier eine Serie machen mit 35,6. 2 Bilder pro Sekunde. Ich schaue, dass die Röhre wirklich tief liegt.
The anesthetist is now asked to hold the patient's breath. An overview of the celiac trunk is made. Here we can see the sidewinder's position in the celiac trunk and the ramification of the splenic artery. We see that the ramification of the liver artery and the splenic artery is here. The vessel's ramifications, as we will see soon by MRI, slope down, a vessel with a relatively small diameter. We see the branch of the GDA, we see the collateralization to the mesenteric arteries. We see the left segment arteries from the hepatic artery segment 2 and 3, a mid-liver artery with a very thin diameter over here, and again the right liver artery. Despite our 35 ml of contrast and despite our flow of 6 ml a second, there's little evidence, little signs of the HCC nodules. I suppose they should be here and here in the right liver lobe. That means we will penetrate into that region, into the right liver, using a microcatheter, performing a series beyond the spleen which has stolen us so much contrast. Target region of our today's intervention is the right liver lobe. Here we have our HCC. Our techniques imply starting with one liver lobe and treating the incidence of HCC at the second liver lobe within 4 weeks. On this patient we will have to do that. I will now try to place our microcatheter into the right liver artery. For example, this position seems very good. In this position, then we will perform angiography over the microcatheter. And then we will discuss the situation as it appears at this specific time, making up our mind how to proceed in this patient. Now we prepare our microcatheter. We will use a 2.8 French pro-grade microcatheter. For flushing, we will not take out his microcatheter wire. After pushing the insert wire which I have hooked up, I will flush the coaxial system using a 1 milliliter syringe with some force. I'm using saline for flushing him. This works very well. The microcatheter container is then flushed by using a 20 milliliter syringe with saline. The Ipsen connector is placed on the table.
Ja, wir haben jetzt den Monitor halt so positioniert, dass Sie gut sehen können, sonst wäre er jetzt etwas weiter weg. Okay. Von der Anatomie denke ich, dass etwas...
The anatomy shows us that it would be of advantage during probing the celiac trunk to bend the microcatheter wire a little bit more. This means the wire tip is a bit bent forward. The microcatheter is now pushed forward approximately 30 cm through the Ipsen connector, and then the microcatheter is fixed in the Ipsen connector. Please, you should never apply force, but you have to fix it. In the meantime, the assistant physician prepares further 2.5 milliliter syringes, 2 for the contrast medium and 2 for saline. The white marker created by using leukostrip labels applied to the syringes means the content is contrast media. No marker means it's saline inside. In addition, the Ipsen connector is prepared. We now prepare the next syringe with 10 milliliter of saline containing 1000 micrograms of nitro, and we're marking that with a white leukostrip. This syringe with nitro is intended to be applied for intra-arterial administration. Before undertaking the next step, the reference image is transmitted to the right screen here, and a roadmap now is prepared. We use a 22 magnification as the sidewinder should be still visible on our screen. We ask for temporary respiratory arrest of this patient to perform roadmap. Thereafter, the patient can continue to breathe. The roadmap is satisfactory. That's an advantage to intubate the patient. We now continue to proceed with the microcatheter, and from that point we are using only our 2.5 milliliter syringes. Again, the microcatheter wire is inserted. It is important never to insert the microcatheter if the wire tip is not pushed out of the microcatheter front side. Okay, the wire tip is now visible and it goes directly into the splenic artery. The microcatheter is now pushed a little bit further.
Habe den Ipsen-Connector sanft geschlossen und werde ihn auch noch spülen.
The Ipsen connector is smoothly closed and flushed using a 20 milliliter syringe with saline, and so the Ipsen connector is smoothly opened, injecting saline and closed again during injection, and now the Ipsen connector is completely free from blood and air.
Gut, wir wollen jetzt in die Leberarterie kommen.
Now we will go for the liver artery. You can see, contrary to our first attempt, how I slightly retract the microcatheter. And this allows the microcatheter wire to adopt the bending which I created.
So, wir sind jetzt auf Höhe des Abgangs links, wo ich nicht hinein will. Das war jetzt. So, ich schiebe mal den Mikro nach.
The wire is now located at the height of the branch. The microcatheter is pushed forward, which is of help. The wire now goes upward to the right side.
Bin in der rechten.
This is the right liver artery. We wanted to go along the branch in the middle, which we have attained.
Ich schließe den Connector sanft. Ich nehme den Draht heraus. Gebe das bitte ins Wasserbad damit.
The Ipsen connector is smoothly closed and the microcatheter wire is taken out. The microcatheter is flushed with saline solution.
Okay, wir werden
Now we stop the roadmap.
stellen uns jetzt
The complete right liver lobe is depicted with one magnification level less. Now we use the contrast pump again.
Wir werden die Serie durchführen mit
The series performed using 13 milliliter contrast medium in a flow velocity of 2.5 milliliter a second at 800 psi. However, you should always know the maximum pressure which can be applied to your microcatheter. Here we will perform our contrast medium series over the ProGrade microcatheter with 800 psi. We are asked again for respiratory arrest of the patient.
So, Serie kommt.
After the DSA series, the patient can continue to breathe.
Sie haben gesehen, dass ich
We have been a bit too optimistic regarding the amount of contrast medium. That's why we have caused a considerable backflow of our contrast medium.
hier ist meine Mikrokatheterspitze und wir haben rechts hier unten dargestellt das HCC. Wir haben hier
Here's the microcatheter tip, and in the lower part of the right liver we can depict the HCC. Here also, and here is the third one. We also see the nodule, the next HCC in segment 4. It seems to be supplied by two branches. As we have already discussed, we will focus today on the right liver lobe, and in 4 weeks we will focus on the left liver lobe. There are some questions which we should discuss. First, is it possible for a better placement of the microcatheter? Another question is whether it is possible to proceed to a more peripheral region. From this location here, we will perform a DSA manually, continuing to completely embolize the right part of the liver. This is the plan we will realize. Again, we transmit this image to the right screen for orientation. We increase the magnification to a field of 16 cm, and again the roadmap is activated. Here again we need aspiratory arrest. When the roadmap has been fixed, the patient is allowed to continue to breathe.
We now prepare a run-through intermediate wire, the 0.014 probing wire, which is a very big help if we treat arterial stenosis after liver transplantation. We learned in this fresh liver anastomosis that he is causing very few spasm. It's a very safe wire.
We would like to penetrate a bit deeper into that siphon here. Therefore, I will slightly bend the wire tip with my hard mandrin from the Seldinger puncture needle.
und das habe ich gemacht.
The 0.014 wire has a length of 1,80 meter. The microcatheter 2.8 has a length of 135 meter.
Da sind wir. Manipuliere jetzt den Mikrokatheter.
We have pushed the wire sufficiently forward. And then thereafter I push my microcatheter behind. Okay, this is deep enough now. The wire goes back into its container. We leave the roadmap and I do a contrast medium series, again manually, to check our positioning.
Vielleicht eine Vergrößerung wäre das.
We increase our magnification by one more level. Unfortunately, this is not enough, and we have to continue with a wider aperture. The ribs are now blanked out. I flush the microcatheter, again with saline.
The patient's respiration is again brought to arrest. He will be embolized from this position, and of course we will embolize him without backflow, only free flow embolization forward. For that purpose, we carefully embolize under direct vision, under fluoroscopy, and we will adapt the pace to the flow velocity. You see, there's no backflow, and we have surely reached all HCCs we have seen. This position allows us to attain all 3 HCC at the right liver lobe. We have reached the optimum position from where we now start embolization. Together we will now prepare the particles. They have already been loaded in the hospital pharmacy. We don't load them ourselves in the angiography. And so the particles are loaded by the pharmacy with the type and concentration of cytotoxic drug which we require. For example, in the morning prior to the scheduled intervention, the particles are generally sent to the pharmacy. We'll get them back relatively quick in loaded condition. We will use, in this case, TANDEM 75 micrometer 3 milliliter. The advantage of using 3 milliliter here is the fact that they can be loaded well with 150 milligram of doxorubicin. This means we will have a relatively large amount of particles with the maximum dosage of DEB-TACE encompassing 150 milligram of doxorubicin. In the upper syringe area, you see a level of liquids that have been separated well. Prior to continuing preparing the particle, it is important to wear protective glasses and a second pair of gloves. It must always be ensured that the three-way stopcock is closed correctly. The side port is opened and the supernatant is suctioned with a 5 milliliter Luer-Lock syringe. For that purpose, the side port is opened and the supernatant is suctioned until the particles are on top in the three-way system cone. Then the three-way stopcock is closed again. We only need 12 ml of contrast medium and therefore we use a 20 ml syringe. The contrast medium is added to the particles. It is very important to ensure that the three-way stopcock system is completely locked during the flushing and mixing of the particles. With even a very slightly oblique position of the three-way stopcock system, sharp edges in the system emerge which might definitely deform or even destroy the particles. The larger the particles are, the more problems would cause such a mechanical destruction. Now we add 4 ml of saline solution and flush them shortly. I now place a 1 ml syringe at the three-way stopcock to be able to withdraw air immediately. It is of help to hold the syringe in a precise vertical position to withdraw a maximum of air. Now the particle preparation is finished. We want to embolize the right liver lobe. The vessels are very small and smooth. For that reason we will administer 200 mg of nitro intra-arterially over our microcatheter. Every single step performed during intervention is documented on a board in our angiography suite. Chemoembolization of HCC with doxorubicin does not include a standard administration of nitro. However, a DEB-TACE with irinotecan, such as the treatment of liver metastasis of colorectal carcinoma, include such nitro administration intra-arterially by default. As a next step, the administration of pain relief is in general discussed with the technicians. In our case, however, the patient is intubated, which is rather unusual for a DEB-TACE, of course. Here, in the needs of the patients, we are of utmost importance and not the embolization requirements. In our case, the anesthesiologists take care of pain medication. We have now prepared everything and start embolization. First of all, the microcatheter is reflushed. When you work with lipidol and have marked your HCC with lipidol, working thereupon with drug-eluting beads, it is very important to flush a microcatheter in these cases very well. I now open the stopcock and I connect my three-way system. As you see, before every embolization, I flush the 1 ml syringe connected to the 20 ml reservoir with my loaded particles 4 times. Then I open the three-way stopcock system to my microcatheter. The microcatheter has a dead space volume of 0.5 milliliter, which can be filled with particle solution without any control under fluoroscopy. Now we inspect the microcatheter position again, for which we use a 22 cm zoom with slight tilting to ensure that behind the microcatheter there is no bone. I start now with the embolization. It is an optimum when there is soft tissue behind the microcatheter, which makes it possible for us to see a potential backflow of our particles.
Well visible at the tip. We can see a cloud, and then we can observe how the particles are transported by means of blood flow. This is called a free flow embolization. The bloodstream serves to transport the particles into the right liver lobe and to embolize the HCCs, which are hypervascularized focuses. Flow is not very quick. I embolize very slowly. I try not to exceed now a velocity of 1 milliliter solution a minute during my chemoembolization. This is very important if you use DEB-TACE with irinotecan. I very much like to start an embolization looking at the first particles, how they behave and their flow. I look at the speed in order to be able to inject the next particle solution without the help of further fluoroscopy. So you will attain lower fluoroscopy times, and so the radiation dose for the patient for all persons in the room will be lower. When flow gets slower in the further course, you have to adapt your flow speed. We will inject then at a considerably slower pace. As an alternative, you can over-dilute your particles, your solution at the end of the embolization, by adding once again more saline solution in contrast. I do not perform that in case of HCC, but this is a very good alternative when embolizing liver metastasis of colorectal carcinoma. We perform an overview angiogram using our DEB particles. Acceptance is still good, and we continue to embolize. In the meantime, we have proceeded quite a bit. You see, flow speed is still high. At the beginning, we had 20 milliliter solution of particles, saline, contrast, and doxorubicin into total. Regarding a flow speed of around 1 milliliter a minute, we will require at least 20 minutes for embolization. When you are experienced with TACE and DEB-TACE, and if you observe a good penetration of particles by the liver, you can embolize quicker. And generally, we seek to adapt the embolization speed to the actual conditions. You see, penetration of particles is still very good, and there is still no backflow. Sometimes our particles are not very well visible, and this does not only apply to chemoembolization. And it's important to know that you have a possibility to make the particles very well visible. This is just perform a DSA. Once again, patient respiratory arrest is required, and you see the amount of contrast agent in your solution is actually sufficient to realize a perfect DSA series. Now I will continue to inject, and you can perfectly see into which region our particles flow. You see, there's no backflow. We still experience the particles to be very well accepted. The patient can now continue to breathe. In some cases, it may be important to perform a short DSA series. For example, if you have a very fast flow, and then the particles may not be very well visible. Now we are at half time. We have already injected 10 milliliter of our solution of 20 milliliter. We have already injected, therefore, particles loaded with 75 milligrams of doxorubicin. You can see now that the arterial vessel bed is filled more slowly. Subtly, you can see segmental arteries at the right side, and now they are more and more visible. This means that we more and more approach the point of stasis. We are considerably closer to our endpoint of the first stasis. However, we can still continue to embolize as the vessels still take the beats up. In the meantime, you see that the right liver lobe and its vessels are completely filled. We will now stop here, referring this moment as first stasis. You see that the deeper, smaller branches are completely filled. There are still no backflow, what we do not want at any rate. We now start to switch on a stopwatch, and in 3 minutes we will continue to embolize without any flushing in the meantime, until we will attain the second stasis.
This means our endpoint is embolization until the first stasis is reached, waiting for 3 minutes, and then continuing to embolize to enable the particles for distal penetration of the tissue, then repeating embolization. Why? You have to decide an endpoint which can also be perceived and reproduced by other colleagues in your department who continue to perform embolization. This is very easy. Stasis, waiting for 3 minutes without flushing, and then continuing to embolize until stasis attained again. Now we wait some time in order to continue to embolize thereafter.
Warten wir ein bisschen und dann werden wir weiter embolisieren. Wenn Sie sehen, es ist 3 Minuten 50.
We have been waiting now for 3 minutes and 50 seconds.
Sie schon mal langsam zu injizieren.
You can see that the embolization particles, that our solution, have once again been absorbed completely. This means here as well that the particles penetrated deeper in our tumor feeder, in our segmental arteries. This shows why the waiting time has such an impact on the embolization success. Not only in DEB-TACE, of course in UFE it would be the same thing.
1, 2, 3. So, wir machen jetzt noch ein bisschen weiter. Und Sie sehen, okay, im Vergleich zu vorhin.
Compared to the last time point, we now experience a slight backflow here. Look here.
Ich muss jetzt meine Technik anpassen und deutlich langsamer.
We now have to adapt our technique by injecting at a considerably lower speed. Useful technique here is to tightly hold the Cern's piston with your fingers, triggering off a little bit.
Und Sie sehen, damit gelingt es mir jetzt wieder sehr schön, ohne einen Backflow, mein Gefäßsystem langsam wieder zu füllen. Ich gehe wieder runter von der Durchleuchtung, wir sind jetzt erst bei 10 Minuten. Und Ziel wird jetzt sein, wie vor unserem Stopp es schön.
Proceeding this way, we always successfully embolize without backflow. It is our target to refill the vessels to stasis again, as before when we stopped. We slowly and continuously proceed to embolize. Now we have roughly reached the same point we attained 3 minutes ago. Of course, you could discuss now whether it would be better to wait again 3 minutes and then to start with the third embolization again. But we do not see the particles. These are not visible. What we see is here contrast agent standing. This means we have a standing contrast agent column filled with particles.
Ob jetzt die Partikel bis hierhin gerutscht sind oder bis
And there's no common opinion whether the ideal point to stop is the second stasis attained after 2 minutes or the third stasis after 5 minutes and so on. And there is still much scope for further studies. This could also influence the actual devascularization result.
We approach the end of the embolization. Since the first stasis point, we have again embolized for 4 minutes.
sehr gut gefüllt. Ich stoppe mal.
Now we are facing again stasis, there is no uptake anymore. We document the result as follows. We have attained second stasis with the 3 minutes of waiting time. We will not perform a DSA series. Reason? There are now particles in this column of contrast here everywhere. And if we would perform a DSA series with the contrast agent pump, then the contrast agent jet would hit the non-moving particles and would whirl them up. This could create a backflow of particles. This would create a non-target embolization, for example, of the GDA. And that means, in the worst case, a necrotizing pancreatitis.
Der zweiten Stase. Da unser Mikrokatheter sehr tief liegt, ist das in einer wenigen Fälle.
With this image of the second stasis, we finish the embolization. As our microcatheter is placed very deep in the liver artery, this is one of the few cases where I actually pull out both mother catheter and microcatheter. As soon as the assistant physician pulls out the sheath system, the patient will wake up.